Good morning, everybody. Welcome back to the Journal Club. It's great to see all of you joining and connecting this early in the morning. Today, I'm pleased to say that Guido will be presenting the JACC state-of-the-art review about CTO and a global crossing algorithm, a really impressive and a big piece of work. And so looking forward to seeing, Guido, your summary of this paper. And then a warm welcome to Alessio Manna, who's joining us from the beautiful Catania. Thank you very much for joining us and to spending some time to share your experience and insights. So Guido, if you can share your screen and we can get started.
Yes, thank you, Arif, for the presentation. First of all, I want to thank Alessio that is joining us today, and it's a great pleasure to see him on the screen in this Journal Club. This is the first time that we talk about CTO, I think, in this Journal Club. And today we will talk about the publication of this global algorithm that is published just a few months ago on JACC. So I make just a brief introduction. Everybody knows that the success of CTO PCI significantly improved during the past decade from 50% to 94% in the expert hands. And in addition to technological advances, this improvement was catalyzed by the widespread implementation of the algorithm. But several regional algorithms were published with some differences in crossing strategies. So for an example, this is the hybrid approach, the hybrid algorithm that was first published. And in this hybrid algorithm, the first two key points were the dual injection and angiographic review of the dual injection. So after this injection, we have to focus on three key characteristics of the CTO anatomies. That is, first of all, the morphology of the proximal cap. If the proximal cap is tapered, blunt, or ambiguous. Second, we have to look at the distal target of the vessel just beyond the distal cap in order to assess the presence of diffuse disease or the presence of major branches close to the distal cap. And third, we have to look at the intervention collaterals if are appropriate to negotiate with the devices and perform a retrograde approach. So after this look at these three characteristics, we can choose to go antegrade or retrograde. So if I have an easy morphology of the proximal cap that is tapered and the lesion is short, I can go antegrade, taking into account that if the lesion is very long and longer than 20 millimeters, probably I have to perform an antegrade dissection and re-entry. This is the Asian Pacific CTO algorithm that was published after the first one. And in this algorithm, the first difference is to differentiate the CTO anatomy in instant occlusive restenosis or not. In case of isolated occlusive instant restenosis, the authors suggest to consider the use of crossbows as primary crossing strategy. And in case of proximal cap ambiguity, the authors suggest the use of an ambus-guided entry to perform an antegrade recanalization. And another focus that authors made in this paper is to consider the primary use of a knuckle wire technique as a dissection re-entry strategy in case of an ambiguous course of the CTO in total segment, and in case of heavy calcification and length of the CTO that is longer than 20 millimeters. And this is the last algorithm that was published 2 years ago, the EuroCTO Club algorithm, in which the authors make the first difference in instant or non-instant CTO. And after this, they focused on the antegrade techniques to resolve a proximal cap ambiguity. And for these authors, we can perform all the techniques that are available at this moment, such as base technique, scratching mode technique. So these two techniques are the move the cap, as mentioned as move the cap techniques, or we can perform an ambus-guided puncture. And another concept that is new in this algorithm is the concept of the investment procedure. So if we have tried all the strategies and all the techniques, but we are not able to cross the CTO, we can perform an investment procedure ballooning the subintimal tract of the CTO that we have already opened, and reschedule the patient 2 or 3 months after to reperform a CTO recanalization. But coming back at our paper, there are many authors, more than 100 operators, expert operators, coming from more than 50 countries that have collaborated to develop this global CTO crossing algorithm, with the aim to standardize the crossing strategies in order to encourage discussion, promote research collaboration, facilitate training, and improve outcomes of CTO PCI. And this global algorithm consists in 10 steps. The first 2 steps are basically the same of the hybrid algorithm. So we have to perform, first of all, a dual angiography, unless the collateral circulation originates from the ipsilateral vessel. And after this, we have to review systematically the angiography, and we have to focus on 4 chart tricks that are paramount. First of all, the proximal cap morphology. Second, the CTO lesion, so the length, the presence of tortuosity or calcification inside the CTO body, and the quality of the distal vessel, if it is a big vessel or small vessel, if it's diseased or not, and if there is a major branches closer to the distal cap. And last but not least, the presence of the collateral circulation, so the type of collateral circulation, if epicardial, septals, or bypass grafts, the size, the presence of entry and exit angles that can be difficult or not, and the presence of tortuosity or multiple bifurcation inside the collateral circulation. So at this point, the first step is in this algorithm is the presence or not of a proximal cap ambiguity. This is one of the things that is very important for every CTO operators, because in case of proximal cap ambiguity, you don't know exactly where is the cap, the proximal cap. So initially, in order to resolve this ambiguity, you can perform a different projection in angiography, or perform a contrast injection through a microcatheter, paying attention to not create an hydraulic dissection on the proximal cap. Or maybe you can perform a CT scan in order to clarify the anatomy of the CTO. But if there is a proximal cap ambiguity that is close to major branches, and you have room enough to put an IVUS probe into the side branch, you can clarify through the IVUS the location of the proximal cap. At this point, you can perform, like in the panel B, an IVUS guided puncture of the proximal cap and go through the CTO vessel. But if you are not, you have not some room to put this IVUS probe in the side branch, you can perform a retrograde approach and use the retrograde wire like a marker wire in order to clarify the proximal cap location and puncture antegradally, and then perform what you want, a reverse cart or maybe else. But if there is no presence of a side branch close to the proximal cap, you can perform other techniques. Such, in this case, in the panel A, we can perform the technique that I mentioned before. So you can go retrograde and use the retrograde wire like a marker wire, or maybe you can perform move the cap techniques. So you can dilate a balloon. This is the base technique in panel F. You can balloon the proximal segment of the vessel and create an iatrogenic dissection plane in which you can go with another polymer jacket wire in knuckle fashion in order to perform a ADR or a dissection and reentry that may be also in retrograde fashion, so with the reverse cart. So you can perform this technique and remain in the architecture of the vessel without any problem with perforation. And after the third point, there is the step 4. So we have to look at the quality of the distal vessel, because if we have a poor distal vessel quality, we have to go retrograde. If we have a major branches like in the cracks in the right coronary artery, and the distal cap is close to the cracks, if we go antegrade, we have many options to lose the PL or the PDA. So in the right way to perform a CTO recanalization in this case is to go retrograde in order to save all the branches that are closer to the distal cap. And the step 6 is when you go antegrade, you can go in subintimal in extra plaque course, and in this case, the authors made some difference and say that all the available techniques and devices that we have to now in the cath lab can allow the CTO recanalization in this case. So if we have a subintimal tract of the wire, like in the panel A, we can perform an ADR technique with a device dedicated for ADR, such as the Stingray device, and we can puncture the subintima just beyond the distal cap and perform an ADR recanalization. But also we can perform a parallel wire technique with or without the use of a dual lumen microcatheter in order to perform the recanalization. Or if it is not possible, we can go retrograde and make a reverse cart, in this case, like in the figure C. So at this point, the step 7 is the retrograde approach. In this algorithm, in the global algorithm, there are some differences with the previous algorithm, and in this case, we have to perform a retrograde procedure, in particular, especially, and when we have an ambiguous proximal cap with poor distal vessel, with a feasible retrograde option. And we have to perform a re-entry and dissection, retrograde re-entry and dissection technique preferred over the retrograde wire escalation when the CTO segment is very long, where there are severe calcification, and when the course of the vessel is ambiguous. And the preferred technique is, of course, the reverse cart. So the step 8 is when to change strategy. For the authors of the global algorithm, there are not any recommendation to change strategy instead of the Japan CTO algorithm, where there is a recommendation of 20 minutes of limit to change strategy. So after 20 minutes of wire manipulation, if you don't have any progress in the CTO body, you have to change strategy. But for the global algorithm, for the authors, there is no recommendation because it depends on expertise of the CTO operator on the case. So there is no any deadline or any time limit for the change strategy. And the step 9 is the concept of investment procedure that we just see before. And the step 10 is when to stop. This is not this is an important message because we have to know when to stop. And for the authors, we have to stop. We have to consider to stop when the procedure is longer than 3 hours and the operator or the patient is tired, or when we inject more contrast than 3 times of estimated GFR, or when the air kerma is more than 5 grays, unless the procedure is well advanced. So, in conclusion, the global CTO algorithm is a melting pot of previous algorithm that can overcome the regional difference And the aforementioned steps could help CTO operators to standardize the approach worldwide, improving safety, reproducibility, and efficiency of the procedure. And it could help to improve the outcomes of this challenging procedure, expand discussion, research collaboration, and training in CTO PCI. Thank you.
Great. Well, thank you, Guido, for that presentation and the summary. It's quite a long, complex topic, so well done on summarizing it. Dr. Manna, if I can invite you in then to maybe start the discussion. I think we can start with from the perspective of a fellow who is, let's say, first approaching a CTO. So often when you do the diagnostic angiogram and you see a CTO, and usually, you know, one shot, okay, that's a CTO, stop. But obviously from a CTO operator's perspective, it would be nice for us all to know that if we had to give you a high quality CTO level diagnostic angiogram, what sort of things would you be looking for, and what advice would you give to us in terms of how to perform the angiogram?
Well, first, good morning, everybody. Thank you very much for inviting me to this fantastic initiative that I like so much, and I'm very happy that the JACC has prompted this kind of update for the young interventionists. So, of course, it's very important to know how to perform baseline coronary angiography when finding a CTO, because, of course, that is a very good time to get some important information that can be implemented when performing the dual angiography at the time of the CTO. In order to procedure planning, of course, baseline angiography is very important. So when you perform your coronary angiography, you find the CTO, it's very important, of course, to do all the different angios in the different angulations in order to try to assess the morphology of the CTO and all the collaterals providing filling of the distal vessel. So you should perform a complete angiography. Many times we see some coronary angios where you just do one shot once you see a CTO. That is not the right thing to do. You have to perform a full angio to give all the different views, and in particular, according to the vessel that is occluded, some specific views should be performed in order to assess the collateral circulations. In particular, the right views, the cranial and caudal oblique right views are very important in order to assess the septals, or the left views for the epicardial collaterals. So according to the location of the CTO, we should do some more views in order to assess the collaterals. This is very helpful when you see the baseline angiography to plan, of course, the CTO PCI.
Okay, thank you. And then you found the CTO, you've done a good diagnostic angiogram. Then nowadays, let's say 2021, with all the literature that's coming out about ischemia and angina symptoms and quality and quantity of life, what is your, let's say, current approach when you're faced with a CTO in the setting of chronic stable coronary disease, in terms of functional testing, in terms of ischemia testing? What is your general preferred strategy in this setting?
So if the patient is already on optical medical therapy and is symptomatic, I don't think that there is any need to perform any stress test. If you have a single vessel disease and the occluded vessel is the main. So in that case, once the patient is already on optical therapy, I think that you should go for CTO PCI. Of course, there are many other patients who are stable, but are, for example, multi-vessel patients or patients with low ejection fraction. In these cases, the management is a little bit more complex if we have to work according to guidelines, of course. So if you do, if there is a multi-vessel disease, you normally revascularize all the vessels. Then according to LV function, the presence of alteration of the segmental wall motion, I decide whether to perform ischemia testing or not. Of course, ischemia testing is important in terms of extent of the area of ischemia, because it's correlated with prognosis. You know that the ischemia trial has challenged this concept, but I believe that still guidelines, of course, guide vascularization according to ischemic extent. And there are so many data according to that I still work in that sense. So I guide revascularization, whether it's CTO or not, according to the extent of ischemia.
Okay, thank you. So the fellow has done, let's say, the perfect angiogram. You've done the appropriate ischemia testing. You've made the decision, we will take on the CTO. Now, coming back to something that Guido mentioned during his talk, how often and in what situations would you consider doing an additional CT scan?
Well, I rarely perform CT scan in CTO patients. This, of course, only in case, mostly for RCA CTOs, when the course of the vessel is ambiguous, and we have very long CTOs and many calcifications. So, or in second attempts, when first attempt fails, and sometimes you understand why you fail, that may depend on the vessel course. In that case, I use CT, but it's very rarely for me, because it's additional radiations, additional contrast. So I think that we should use it very, focused on specific patients.
Okay, thank you. So I'd also like to invite, if anybody else has any questions, we'll keep going with the discussion. But if anybody does have any questions, please either type or just turn on the microphone. We're here really with a real expert. So now is the time to ask all your questions or dilemmas you've had in Cath Lab.
Good morning, Alessio. This is Julia. From an anatomical point of view, is there any typical situation in which you skip an antegrade approach and you start with a retrograde approach first, from the first line approach?
Yeah, of course, retrograde first is normally used, for example, when you have very long and tortuous, very long occlusions in very tortuous vessels. Like a typical example is the proximal RCA occlusion with a very long length up to the cuts, for example. So in that case, the retrograde approach for me is the first approach, because when you perform antegrade, you need to have a good, landing zone. It means that the quality of the distal vessel must be good. You can even try an antegrade approach in very long occlusions, maybe if the vessel is not very tortuous, because you can be successful in wiring the distal vessel. But you have always take in mind that you need the next option in case you go subintimal. So if you go subintimal, you need to re-enter. With an antegrade approach, you need a good distal vessel in order to try to be successful, to increase the rate of success with the distal re-entry. So it's very important, of course, the anatomy, the length of occlusion, where is the distal cup, and the ambiguity of the proximal cup is another important. But even if the proximal cup is ambiguous, but you have a good quality of the distal vessel, you can still do an antegrade approach with, of course, the option of performing a distal re-entry, antegrade re-entry. That can be device-based or not, of course.
Okay, so coming back to our patients, so you've decided to do the CTO, you've planned everything, patients on the table, access. What's your preferred access strategy in your CTOs?
Well, now in the last few years, I moved from a femoral-based approach to a radial approach for CTO. So my standard approach is biradial. If the patient has good, of course, good radials used, but it depends, of course, on the anatomy of the coronary arteries. And very important is the experience of the operator who performs the baseline angiography in terms of backup when he performs the angios. So if the previous angio was performed by radial and the backup was good, in particular for the right coronary artery, I go for biradial in most of cases. Because nowadays, of course, you can use the 7 French guide even from radial, so there is no limitation for this kind of approach. In some situations where you see very calcified vessel, situation where you may expect more difficult procedure and you need a very strong backup, in that case, I use an hybrid approach based on the radial plus femoral routes.
Okay, thank you. And now we come to probably the thing that certainly gives me the most palpitations when, scrubbed in CTO procedures is equipment. There's just a phenomenal number of equipment, wires, balloons, devices. So as fellows who are starting in interventional cardiology, forget even CTO, but with an interest in CTO, how would you advise that we should even begin to approach this, let's say, huge catalog of devices and wires in CTO? Because obviously when you're working in the table, you're working quickly and you're trying to remember whether this in my hand is the Gaia 2 or the Gaia 3. I have no, you're trying to remember. But could you just share some tips or how you learned, for example, which would be very useful for us?
Well, of course, there are nowadays, as you said, there are so many different wires, microcatheters. Some of the wires are very similar anyway among the different companies. So what is very important is, of course, there are some must-have wires, for example, the Gaia wires, because there are some specific features that make these wires unique. So in my opinion, the Gaia series must be available. Then there are, of course, it's very important to have soft cover polymeric wires, because they are, in most of cases you start with such kind of wires, and these wires now are available from many companies and are very similar. So what is important is to have such kind of wires. And of course, penetration wires that are very important. And again, now we have an ability of different components providing these wires. So you need to have this different kind of wires, and then of course microcatheters. Microcatheters, now there are many microcatheters. What is important is to have again different type of microcatheters according to the use you are going to do. So you need coiled microcatheters that are very important to perform retrograde approach and for septal, for example, crossing. But even softer microcatheters can be used for an antegrade approach or when you have to perform an epicardial crossing. So what is important is to have in your own cath lab different types of guide wires and microcatheter. Doesn't matter whether they are of this company or another. Nowadays they are very similar in most of cases, but there are specific devices that you have to have, that need to have, that are very specific and cannot be, replaced by others.
Okay, thank you.
It's very difficult to have any kind of guide wires and microcatheters in a single cath lab, and it's very difficult to get experience with of these devices. So you have to learn how to use some of these devices, and then you move to other if you want to expand your knowledge, of course.
Okay. And then obviously one of the most dramatic things sometimes we see during CTOs are complications. And they can be sometimes also quite difficult to even understand what's going on and what's happening. So, a few words about CTO specific complications and are there specific, let's say, approaches that you do differently, or do you have a slightly different mindset for CTO complications?
So the fact is that, of course, you want to start CTO PCI, you have to be a very good experienced cardiology in PCI and complex PCI. Even young operators now can start performing CTO, but they need to have a very good background in complex PCI. Because first you have to be able to manage complication in standard PCI, and then start to be ready to manage complication in CTO. Because CTO complications are much more complex, sometimes very put the patients at risk. So it's very important to be first a very good and experienced operator for CTO, for complex PCI. In case of CTO, of course, complications rate is higher. We know that. So it's very important, of course, dedication to PCI, as we discussed before, because it's a stable patient, often without chest pain. So of course, you have to ready to face, complication and to explain why you perform that PCI, of course. So the risk of complication is higher because perforations are at increased risk in CTO PCI. Perforation can depend from distal perforation, whether to collateral rupture. So you may have different kind of perforation. The most complex are, I think, the a collateral vessel rupture, because, for example, epicardial or even septal sometimes, because it's not always possible to control the bleeding. So even you are able to use coils or other devices, sometimes you cannot stop the bleeding because there are so many connections among septals that sometimes you start to coil what you think is the site of bleeding, but it keeps bleeding again. So it's very important to you will be very good operator first to face complications with an experienced operator. So it's always important to work together with a senior, not in terms of age, but in terms of experience, a senior operator that is more keen to manage complications. And of course, you have to follow courses, like cases. But what is important is to perform CTO PCI at the beginning with experience, together with other operators that were experienced or even proctor. Because if the more PCI you perform, CTO PCI, more is the likelihood of facing complication and to see how to manage them. So this is very important.
Okay, thank you. So I think we've just come to time, so that's perfect timing. So I'd just like to say, Guido, thank you so much for presenting that global crossing algorithm from JACC. It was a really big article and a really nice summary for giving us a step-by-step approach. And Dr. Manna, thank you so much for joining us and sharing us really from, let's say, from start to finish with these procedures, a step-by-step approach, and also your experience and insights. Really helpful, really appreciate it. And thank you for joining us so early on a Friday morning.